Moving right along, bowel obstruction. We're still in the world of elimination concept. The whole point is to getting what out of our body? Getting the waste out. Waste doesn't, we can't keep waste in our body. We can't keep it in our blood. We can't keep it in our cells. It has to get out of the body for us to be healthy, correct? Just like in the world we live in. What does waste piling up do? Not a good thing, right? So the whole point of our GI and urinary system is to get waste out. If it is obstructed from getting out, problem, correct? So obstructions can be partial, they can be complete. An intestinal obstruction or a bowel obstruction is contents can't pass through the GI tract. It can be a partial obstruction or a complete obstruction. Partial sometimes resolves with conservative treatment. But once someone has had a bowel obstruction, what are the chances of them getting another one? Very good one. Very good. Usually they get another one. Complete obstruction requires surgery most of the time, pretty much. It can be a simple or a strangulated obstruction. Simple, they have an intact blood supply. Strangulated, they don't. Which one do you think is most serious?
Strangulated.
Because if you don't have blood supply, what else do you not have? It's, anytime there is an obstruction, there's a problem, correct? Because you're not getting the blood flow, you're not getting the nutrients, you're not getting the oxygen, and you're not getting the waste away from the site. So, strangulated is more serious. Yeah, this is my third day of lecturing, and my throat told me it's tired. Okay. So, simple is the blood supply is intact, strangulated it's not. Causes can be mechanical or non-mechanical. Mechanical are outside the intestine, such as adhesions after surgery. In the bowel wall, as in Crohn's disease and intestinal lumen, or tumors are blocking the way. It's usually in the small intestine that we have mechanical obstructions. Surgery adhesions are some of the most common cause. They develop days after surgery. Other causes are hernias, cancers, strictures. Common causes in the large bowel is cancer. A non-mechanical is usually lack of motility, some sort of disorder with motility. Your peristalsis is decreased, or there's some sort of neuromuscular disturbance where the nerves are not getting, there's no innervation to the bowel. Any questions? The difference between them all? The paralytic ileus is the most common form of non-mechanical obstruction. Reduced or absent peristalsis related to altered neuromuscular transmission. Vascular disorder may occur post-op abdominal surgery. That's the most common. It's actually difficult to know if it's related to surgery or if it's related to adhesions from surgery post-op, or if it's paralytic ileus. The way you know is usually you get some bowel sounds back if it's an adhesion. That's kind of like the differentiating clue. Bowel sounds usually return before the post-op adhesions develop, so that's kind of your clue that it might be an adhesion. Other causes are peritonitis, inflammatory responses such as acute pancreatitis or appendicitis, electrolyte abnormalities such as hypokalemia or thoracic and lumbar spinal fractures. There's damage to the gastrointestinal muscles. It's critical illness, it's shock, sepsis ensues. Opioids, peritonitis, electrolyte imbalances, thoracic fractures, hypomotility. Postoperative ileus is hypomotility of the segments of the GI tract. All small intestine motility occurs within several hours. Gastric hypomotility occurs 1 to 2 days. Colonic 3 to 5. It's progressive. It occurs in some degree after every abdominal surgery. Because what do we do whenever we put someone's going to surgery, and they are anesthetized? Everything goes to sleep, right? And do we give them something to eat the minute their eyes open? Because what? Parts of their body are still asleep. This is the same way. So it occurs with abdominal surgery as a part of surgery, because that we put it to sleep. But other causes are whenever these other disease processes come in, it stops motility, slows everything down, and it doesn't come back. It just keeps getting worse and worse and worse, okay? So some of the pathophysiology is obstruction, accumulation of fluid, gas, intestinal contents. The location of the obstruction determines the extent of the fluid, electrolyte, and acid-base imbalances that ensue afterwards. So distal to the obstruction, wherever the obstruction happens, the bowel goes on and empties out the rectum and the anus. Whatever was past the point, distal to the point of the obstruction, goes ahead and gets cleared out, and then it collapses. But the opposite end is not getting cleared out, right? So everything is coming up against your obstruction. So as a result, you're getting distension is increasing, bowel pressure is increasing, capillary permeability is increasing, extra vasation of the fluids and electrolytes end up in the peritoneal cavity. It's kind of like 121 or Dallas North Tollway. When there's an accident, it keeps backing up, right? Everything keeps getting clogged up. And there's nowhere for it to go. If it can't get out the rectum, there's nowhere for this to go except to spill over into the peritoneal cavity. So intestinal muscles become fatigued, peristalsis stops, retention of fluids in the intestine and the peritoneal cavity. This fluids pouring into your peritoneal cavity decreases your blood volume, pulls it down, and when we get a great severe reduction in blood volume, what do we get? A little shock, hypotension shock, so get hypertension, hypovolemic shock, decreased blood flow, and when there's no volume of blood flow to go where it needs to be, what dominoes start happening? You get decreased blood flow, you're not getting the nutrients, you're not getting the oxygen, you're not getting the waste removed for all your system of the body, right? So this gut problem quickly becomes a systemic problem. It's in the gut, but it's affecting everything because the volume just went way down, there's nothing moving, and you've got falling blood pressure, and ischemia happening, okay? And then in that area especially, you're going to get necrotic, there's going to be a perforation, and when there's a perforation into your gut, what's going to happen? Is everything in your gut supposed to, or everything in your intestines supposed to be in your peritoneal cavity? No. So it's a big, the dominoes start falling, right? You're going to get infection. You're gonna get more volume deficit. You're gonna get more ischemia. You're gonna get more necrosis. All this starts, what starts as a obstruction in the localized area of your bowel quickly becomes a systemic problem. You end up with intestinal strangulation and intestinal infarction. If the obstruction in the small intestines isn't treated quickly, the dehydration just starts really quickly. If the obstruction is in the upper duodenum, usually you have metabolic acidosis, which results from the loss of hydrochloric acid because the person is vomiting, or you may have them hooked to NG suctioning, trying to decrease that distension. Clinical manifestations. There's 4 hallmark signs: abdominal pain, vomiting, distension, constipation, based on location and degree. Small intestines, proximal, distal, have different manifestations. Large intestines have different manifestations. So small intestine has rapid onset, large intestine gradual. Vomiting, present in the proximal, less present in the distal, and late onset in the large intestine obstruction. Pain, colicky, crampy, proximal, the pain's going to be at more frequent intervals. Distal is a little more intermittent, and then if it's in the large intestine, it's more persistent. Bowel movements, proximal, you might have feces for a short time because what's happening beyond that obstruction, whatever was there is going to keep going on its journey out the rectum. And then once that is cleaned out and your bowel collapses, there's nothing else coming through. So have feces for a short time. Distal, you're going to gradual constipation. Large intestine, you're going to have absolute constipation because there is nothing coming out if it's in the large intestine. Abdominal distension for the small is minimal, but the farther down you go, down the GI tract, you get more distension. Diagnosis, history, physical, imagery to identify the presence, location, and guide where surgery needs to go. CT scans, contrast enema, looking for a increase in white blood cell count, a drop in the hematocrit hemoglobin. The electrolytes are going to tell us our degree of dehydration, and going to see metabolic acidosis because of the vomiting or the NG suctioning. Collaborative care, treat the cause. The strangulated obstruction or perforation is an emergency surgery, a laparotomy. If due to the surgical adhesion, they're going to resolve it. You can resolve that without surgery sometimes. Most cases of resolve with watchful waiting and supportive therapy. Initial or conservative treatment, the doc's going to take the wait and see look. They're going to place the patient in PO. They're going to insert an NG tube for decompression. Going to have IV fluid therapy, either normal saline or lactated ringers. We're going to be administering analgesics for pain. We're going to try to get the GI motility up. If this is going, according to their nutritional status, they may be put on parental nutrition to allow the bowel to completely rest and improve their pre-op status before they go to surgery. That's going to happen. The surgery may involve simple resection of the obstructed site or a total colectomy or colostomy, ileostomy. Depends on the severity of what's going on. Nursing assessment, history, Determine the location, frequency of abdominal pain, onset. Assess for bowel function, are they able to pass gas? Auscultate the bowel sounds. Inspect their abdominal area for masses, distensions. Assess whether their abdominal tenderness or rigidity is present. Measure the abdominal girth. If they have a true obstruction, what are we going to see happening to that abdominal girth? It's going to keep growing, right? We need to always make sure that we're measuring that. Check for signs of peritoneal irritation, muscle guarding, rebounding. So the intestinal obstruction is a potentially life-threatening situation. Concerns are preventing fluid and electrolyte deficits, early recognition of deteriorating condition, such as hypovolemic shock, sepsis, bowel strangulation. If the healthcare provider does decide to take the monitor and wait and see look instead of immediate surgery, monitor closely for any change in the vital signs, any change in the bowel sounds, any decrease in urine output, or any kind of increased pain or increased distension. And call your healthcare provider if any of that happens. Diagnoses: acute pain, deficit of fluid volume. Goals are to relieve the obstruction, return to normal bowel function. Goal is to have minimal or no discomfort, normal fluid and electrolyte, normal acid base. Monitor the patient for signs of dehydration and electrolyte imbalances. Administer the IV fluids. Watch for signs of fluid overload, such as weight gain, shortness of breath, swelling in the extremities, increased blood pressure. Monitor for serum electrolytes closely. If they have a intestinal obstruction high in the GI tract, they're going to most likely have metabolic acidosis, metabolic alkalosis, and low will be metabolic acidosis. Provide comfort measures, restful environment, monitor for hypovolemic shock, monitor their I&O, manage their pain and anxiety, because they may be waiting to see if they're going to go to surgery, so that's going to increase their anxiety and their discomfort. Some patients, especially older patients, don't tolerate rapid fluid replacement, and they may have fluid overload very quickly. These patients are often very restless and constantly changing their positions to try to relieve pain. We talked about this kidney stone dance. They're kind of doing a dance too, because they have this obstruction, it's uncomfortable, and they're just trying to find a position that they feel better. With an NG tube in place, oral care is extremely important, especially if the patient's been vomiting. Make sure you offer frequent oral care. Encourage brush their teeth frequently, mouthwash. They can rinse their mouth out with water, but remember their NPO. Water-soluble lubricants for the lips. If they have the NG tube in, check their nose for irritation and skin breakdown. Clean the area, provide a lubricant. Check under the tape to make sure that you're not having skin integrity problems, and change the position. Check the NG tube every 4 hours for patency. The NG will lead to low intermittent suction to empty the stomach and prevent gastric distension. Drainage from your NG tube should be, right after surgery, would be dark brown, so light brown, might have some red in it, but after the first 12 hours, you should see it should start changing to light brown, and maybe green if it has bile in it, but it shouldn't be red. Something keeps taking over. Gremlins in the room. Messed up.
So I have a question. Yesterday you stated that you test on exemplars. Okay, so So what I'm noticing all the concerns that I want, so within the exemplar itself, you have all the other disease processes in there.
So yesterday we were on malabsorption. What was your example for malabsorption? Malabsorption is your exemplar, but malabsorption is what? It's kind of a category itself, right? What do we talk about? Celiac, remember? So that's, you look at the exemplars as to what, like some of them are very specific. GERD and the peptic ulcer, very specific, correct? But the malabsorption had bigger pieces to it.
There's a broad topic within.
Some of them are very broad, some of them are more very specific, like renal calculi, or, you know, that's a very specific thing, and it will be there. And that's what I'm going to talk about, is that specific one. But then there's going to be other things like the malabsorption, you know, it was a little broader. So that's the kind of thing, but you're gonna have one, you can pretty much know what the test blueprint's gonna be just by looking at the hours of, like when we did metabolism with diabetes, we talked about lots of different diabetes. That was a bigger chunk than hyper, right? So that's the kind of thing, that's how we line it up. Okay, I did 4 hours of this and I'm covering these exemplars, because they were all listed as an exemplar, correct? So that's how, but I'll send you the, I'll try to send you guys a more specific one if you can't figure it out from what the exemplars are. Okay?
And see, I was gonna ask the same thing about this one, will we know exactly what the exemplars are compared to trying to figure out?
The exemplars are listed in your syllabi. It lists them, every one.
Okay, perfect.
Yeah, they're everyone listed in each one.
Okay,
Just look on your, if you look on your syllabi, it will tell you exactly what the exemplars are. Okay? And you know whether if it's, you know, if it's been a 4-hour, lecture, it's been a 2 hours, you know, that it gets, you know, it's by how much time we spent on it. It gets more attention.
I think it needs to be updated, because with the last unit, it had osteomyelitis for one of the exemplars, and still it didn't correlate with anything we had.
Right, osteomyelitis got moved to level 4, so, but that's been a relatively new change.
Why is it on there?
I didn't make the syllabus out, okay? So it did get moved up, but it does have a lot of similarities to what we're talking about. But what I lecture on, what each one of us lecture on, that's what you're gonna focus on, okay? I didn't talk about osteomyelitis, right?
yeah, isn't that what I just asked? I believe it's still.
It's still in the process, it still relates, because it's kinda hard. I can't say, oh, don't look at osteomyelitis because it doesn't fit in the concept, but it does fit in the concept. And do you think you're gonna have a patient with that in the next little bit? Can you walk into clinical and have someone that you might need the information? So the hard part is, there's lots of, you need to know it all, correct? And you need to know it all, and you need to know it immediately, but that's not how we can do this. So those exemplars are in your syllabi, and what I talk on, that's what is gonna be on it, okay? Going back to implementation. Encourage, brush your teeth, mouthwash, water soluble, check the NG tube every 4 hours. Let's see if I get this done before the gremlin takes my thing again. Manage strict I&O. Urinary cath not allowed for hourly monitoring of urine output according to the condition of the patient. Nursing care after surgeries, notify the surgeon if there's any vital sign changes, issues with bowel sounds, increased abdominal distension or pain, decreased urine output, a change in the creatinine or BUN level. If you have bright red blood coming out the NG tube, it's a problem. If it's been more than 12 hours after surgery, or even then, if it's a lot, like a good amount. NG to low suction, dark brown. to dark red for the first 12 hours, and then it should change. If dark red continues, make sure the surgeon knows. The coffee ground granules may be there at first because it's blood that's been changed by the gastric secretions, but that should be going away. It shouldn't be continuing. Nausea and vomiting and antiemetics, such as Zofran, promethazine, monitor INO, electrolyte status, vitals, early ambulation, early ambulation. They're also at a risk for what if they're not ambulating? They're dehydrated, they're not moving. So what do you think they're gonna have? DVT, very good. Any questions? Any questions? As I said, I'll send you the,
It's pretty cut and dried based off the hours of how long we spent on topic, on that concept, and what the exemplars are, so we just have to syllabi. I am in the process of updating the syllabi because, as all of you know, this is the first semester I'm on this level. I've been on other levels for the later semesters, but this is the first time I've been on this one. So I'm reading everything just like you are. I get to read just like you do. And I'm finding that some of the pages are messed up. So I'm going through and fixing those as I